So this is the case, and first I'll show you the plane images. So as I tell every time, whenever you are shown CT MRI images, you can always say, I will go through the set of images and then start describing. And you can take around 15-20 seconds in going through the set of images and then start describing. Because as soon as the first image comes in front of you, it is impossible for you to have the diagnosis with you. Okay. And don't worry about the diagnosis. Do not worry. Okay. It will come. It will come. When you go systematically, you will definitely come to the diagnosis. And even if you don't come to the diagnosis and your technique is correct, believe me, you will pass the exam. Okay? Now, have you seen the plane study?
Yes, ma'am. Can I see the lung window, ma'am? In my routine
Sure.
practice, I will go through the lung window and bone window as well, ma'am.
Very good. I like it that way. I'm happy that you are imbibing the correct way of talking also. That's what happens when you practice. So rather than that's what he did. He said in my routine practice, I would look at the lung window and bone window rather than asking directly, show me the lung window, show me the bone window. That's not a good way. Okay. So basically, you will be shown films, I think, not the DICOM images. So films, in films, they might be having other windows. They might not be having other windows. If they don't have other windows, you can tell. In my routine practice, I would go through the other windows, whatever window, to look for what that you have to tell. So you have seen the lung window.
Yes, ma'am.
Now you want to see the bone window, right?
Yes, ma'am. Ma'am, can I see the sagittal section once for the bone window, ma'am?
Or the bone window. Okay. Is that okay?
Yes, ma'am. Ma'am, just want to see the lung window, ma'am, once more, ma'am.
Okay.
Ma'am, in the coronal plane.
Okay.
Ma'am, in my routine practice, I would also like to go to the, ma'am, if there is any contrast image available, ma'am.
Yes.
Yes, ma'am. Ma'am, should I start, ma'am?
Yes. Yes. Sure. Let
Ma'am,
me
I
know
am.
when. So you want me to scroll more?
No, ma'am.
Wherever you want me to stop, I can stop there and.
Yes, ma'am.
Hmm.
Ma'am, I am presented with non-contrast enhanced and contrast enhanced images of the chest and abdomen. In the chest, we are given the lung window, bone window, as well as the soft tissue window, as well as in the abdomen. Ma'am, by looking the images carefully, ma'am, in the non-contrast images, I am able to, ma'am, appreciate, ma'am, ma'am, bilateral pleural effusion along with, ma'am, along with bronchiectatic changes. And ma'am, on the right lower lung lobe, I am able to appreciate a cavity with a soft tissue attenuation, is not enhanced on post-contrast scan, as well as I am able to appreciate areas of consolidation and trine bud opacity in post-trabecal segment of right lower lung lobe. This will signify me to a infective etiology. Ma'am, on scrolling the scan further in the abdomen part, I'm able to appreciate, irregular cystic areas in the multiple cystic areas in the spleen, which are showing peripheral enhancement on early to late post contrast enhancement scan, ma'am.
You mean to say multiple hypodense
Along with
lesions, with
yes, ma'am.
peripheral harassment? Yeah.
Yes,
Okay.
ma'am. Ma'am, by combining all the findings, as well as I am able to appreciate ma'am minimal subhepatic collection as well. Ma'am, by combining a finding, I
Anything
come to
else?
the conclusion.
Anything else? Anything else you saw?
Uh,
You told lung
ma'am,
finding, you told spleen
ma'am,
finding.
as well as
Yeah, tell me.
as well as in the liver also,
Okay.
ma'am, in the liver also one hypodense lesion is there, which peripheral enhancement,
Where?
ma'am.
Where?
Ma'am, in the right lobe of liver, ma'am.
Okay. So in the top
Ma'am, in
section
the
or
right
in
lobe
the
of liver.
yeah this okay in the right lobe in the top section or in the lower sections?
Ma'am, in the just right there, ma'am. Ma'am, like in the lower sections, ma'am.
Oh, you can see now, huh?
Ma'am, just
This
above,
one.
ma'am.
This
Yes,
one.
ma'am. Ma'am, one more is there. Yes, ma'am. Ma'am, one more is there.
This one more is
Yes,
there.
ma'am. Hmm. Ma'am, this one, ma'am. Ma'am, just at the, ma'am, just below, ma'am. Hmm. Ma'am, no, ma'am. Ma'am, like in the, ma'am, uh,
I think only this lesion
ma'am,
is there.
just
This
below. Ma'am, ma'am, just near the ribs, one more lesion which is showing peripheral enhancement, ma'am.
here.
Ma'am, below, ma'am. Yes, ma'am. Yeah. After, ma'am, ma'am, slightly, ma'am, this one, ma'am, this one,
Where something?
ma'am, near the ribs, ma'am, this, ma'am, near the ribs, ma'am, like in the segment, ma'am, uh,
You're saying in this region?
ma'am, segment, ma'am, eight. Ah, yes, ma'am,
This one?
ma'am, ma'am, like in segment eight, ma'am, approximately, ma'am.
Segment 8. So that would be anterior and that would be superior.
Yes, ma'am.
I don't see any peripherally enhancing lesion. Okay, this one you're telling me. This one?
No, no, ma'am, in the liver, ma'am. It is in the liver, ma'am.
I'm at the liver only. This is the liver.
Uh,
Okay. We'll come back to that. You
oh,
just keep
okay,
describing.
ma'am.
Hmm.
Yes, ma'am. Ma'am, by concluding the finding, ma'am, finally came to the to a diagnosis. Ma'am, my provisional diagnosis for this case would be, ma'am, like, ma'am, active infective etiology in the lung with areas of consolidation, ma'am, as well as, ma'am, fungal ball. and ma'am,
As
which
well
will
as
leading to ma'am,
fungal ball.
my,
Which one is the fungal ball?
ma'am, ma'am, it could be ma'am fungal wall or ma'am infected bronchiectatic cavity, ma'am. I'm not sure, ma'am.
Okay, so you think this everything is infection. So I agree with that, that this everything is infection. Okay, you see multiple splenic
Abscesses is there, ma'am.
abscesses and there is liver abscess. There is only one lesion in the liver. Okay, and these are
Yes, ma'am.
also lung abscesses. These are lung cavitary lesions in the lungs. Okay. So I don't know why you got so confused
Oh,
about them. Well, this is also a cavitating lesion. There are fluid contents in that. This is also a cavitating lesion where there are air contents in that. Okay. So there is no confusion and there are some
ma'am.
adjacent areas of consolidation also. There must be adjacent
Yes,
bronchiectatic
ma'am. Ma'am,
areas.
like
That's not a problem, but these are all cavitating
to
lung lesions, lung abscesses, whatever you call them. But you don't see any better to call splenic abscesses, liver abscesses, and cavitary lesions in the lung or lung abscesses, you can call them.
yes, ma'am.
Okay. So, and
There
anything
is
else you
ma'am
see?
soft. The other ma'am the axis in the right segment of the board sub.
Uh, your voice is breaking. Your voice is breaking.
Ma'am, this will
I
be
can't hear
rupturing,
you.
ma'am, and that will leading to collection.
There is, I think, you think there's a rupture of the abscess which is leading to collection? This one? There is a possibility because it's a subcapsular lesion. Okay. But I can't hear you. Your voice is totally gone. Are you there?
Ma'am, is I am audible, ma'am?
Yeah, now you're audible.
Oh,
Yeah. So
ma'am,
you saw some ascites also.
yes, ma'am. Ascites as well as ma'am subcapsular collection, ma'am, in the subhepatic region. Ma'am,
Yeah, yeah,
probably
that's
due
fine.
to the
It is
rupture of
possible.
these
It is possible
members.
that it is not very sure, but it is possible. Any other thing you want to comment on?
Uh,
Anything which you
ma'am,
see
there is,
here?
ma'am, there is multiple, ma'am, portos, ma'am,
Yeah.
collateral along the splenic, ma'am,
Yes. Good. Very
ma'am,
good.
along
So
the splenic
why do you think
region
there is
as well
splenic?
as,
So there are splenic
ma'am, as
hilum
well as there is
collaterals.
splenomegaly. Yes, ma'am. As well as splenomegaly is also there, ma'am. As well as enlargement, mild enlargement of caudate lobe is there, ma'am.
Okay. So, okay, I agree. You think there is some component of chronic liver disease. That's
Yes,
fine.
ma'am.
That's fine. So, can you see splenic vein or you just see the collaterals?
Ma'am, splenic vein is, ma'am, apparently, ma'am, I'm able to see the splenic vein in the, ma'am, proximal part, but in the
The,
distal part, ma'am,
but here you are not able to see,
yes,
right?
ma'am.
But you are able to
Yes,
see
ma'am.
multiple collaterals at the hilum. So, what does
Yes, ma'am.
that mean? If you're not
Ma'am,
seeing the
splenic
splenic,
vein thrombosis,
yes,
splenic
and
vein thrombosis.
it's a chronic splenic vein thrombosis, secondary to maybe
Oh,
CLD. So chronic splenic vein with portal
yes, ma'am.
hypertension. So chronic splenic vein thrombosis is there. That's why there are so many collaterals as a compensation, right?
Yes, ma'am.
So now what?
Uh, Ma'am, can I see, ma'am, like after the ma'am diagnosis part, ma'am, in the ma'am management part, ma'am, first I like to compare these images with the any previous report is available to look for either the lesion is already present or not for to look the progression of the lesion. Then we will, mm, ma'am, we will further advise the patient
But
for, ma'am,
I would like to guide you at this point of time because this is urgent finding. See, there are abscesses here and there, right? So this needs to be informed urgently first. You know, these are lung abscess, liver abscess, clinic abscess. So first of all, you'll
Yes, ma'am.
inform because abscesses can rupture,
Yeah.
anything can happen. So patient is at risk. So this thing needs to be first
Yes.
informed, and then you will come to everything else.
Mm.
Okay.
Okay. Ma'am, we will first refer the patient, ma'am. After that, we will advise the patient for USG guided, ma'am,
Inform
as
the referrer. You will inform the referrer.
the referral,
And
ma'am.
then, yeah, inform the referrer, and then you can say if there's any previous imaging available, I'll look at that to compare. And then, yes, you can, if you want to advise, yeah, USG guided, um, from
Yes,
some of the maybe splenic lesion, whatever is accessible.
yes, ma'am.
So they can establish the diagnosis from that.
Yes, ma'am.
Right. So, what are your provisional diagnosis? You said abscesses. What do you think? So, this is a proven case of something. I can tell you that, but
Uh,
if you tell me, it's better.
ma'am,
What do you think is the etiology of the abscesses? What
ma'am,
infection? What
ma'am,
type of infection?
tuber, ma'am, tuberculosis,
Yes, in the setting of Indian setting, so we would always think first of tuberculosis,
tuberculosis. Yes, ma'am.
which is very reasonable.
Yes, ma'am.
And hmm.
Uh,
So
ma'am,
and actually, this was a case of disseminated coughs only. So even,
yes, ma'am.
if the pleural fluid aspiration, diagnostic aspiration is so easy, even that would give the diagnosis, isn't
Yes,
it?
yes, ma'am.
So whenever there is pleural effusion or there is some ascites tappable, you can, that's very easy to establish the diagnosis. So because we have to suggest the referrer, no, that you can, uh, this thing can be done, or first we have to discuss that if we are doing it for the patient, and then we have to keep the referrer in the loop for that. Okay. But I think the pleural fluid
Ma'am,
would be the easiest thing to do for this patient.
ma'am, just one doubt, ma'am. Like in the lung lesion, ma'am, is there
Yeah.
any soft tissue or it is the wall thickening,
So
ma'am?
you said fungal ball. Fungal ball in fungal wall, there's a soft tissue within a cavity. This is all liquefaction, you see. This is so hypodense.
Oh,
This is liquefied, okay? This is like necrotic inside. This is abscess.
yes,
It's so
ma'am.
hypodense. That's like fungus ball would be solid appearing, and you will have a crescent sign around it. Right? Here you are not having. So that's like
Okay, ma'am.
within a cavity there is a ball, and around between the cavity and the ball there is a crescent of air. That is very
Yes, ma'am.
classical, isn't it? So I didn't
Yes,
expect
ma'am.
that you will get confused with fungus ball in this case. But a fungal can be a differential. In that, you can say that another differential for this situation is fungal infection. But when does fungal infection happen? When the patient is already
Immunocompromise is there, ma'am.
immunocompromised. So that's very important because not everybody will have fungal infection so easily, right? Fungal infection happen
Yes,
in
ma'am.
immunocompromised states. And what can be the common
Yeah.
immunocompromised states?
Ma'am, diabetic patient is there, ma'am.
Diabetes.
Any, ma'am,
Very good. Very good. So diabetes or any other patient has any,
ma'am, like,
background systemic disease, any systemic disease.
yes,
So
ma'am.
where they are taking on medication, steroids, whatever, like. But yes, diabetes is something which I really wanted to hear from you. And
Yes, ma'am.
so so that's about it. So uh, and you didn't find any bony lesion, right?
No, ma'am. There is no evidence of, ma'am, any bone injury.
Another possibility would be a metastatic lesion, but looking at the lung lesion, they're very clearly infected. So then
Yes,
if
ma'am.
the lung lesions are infected, then it's better to put everything under one umbrella and call
Yes, ma'am.
everything as infective only. So giving two different diagnoses is not a very great idea, right?
Yes, ma'am.
So here it becomes a long case in the sense you have covered chest, you have covered abdomen both. You saw plain study, you saw contrast study, you saw lung window. So you saw so many things, right? And you saw CLD features also. You saw chronic splenic vein thrombosis, where you could not appreciate the splenic vein itself. There are so many collaterals, and you see collaterals here and there, everywhere there are collaterals. See, there is so much of omental and mesenteric fat stranding also. Ascites is there, so some stranding is because of ascites, some is because of CND collaterals, right?